Hello, I am Kyoung-won. In this case discussion, it is already mid-December 2020, nearing the year end. Before we send it off, let's have a very exciting case discussion today. We have 3 clinical masters. Hello. This is the 9th case discussion. Let's have a look at what we are going to discuss. 63-year-old female patient, no specific systemic disease including osteoporosis. If you look at the story from the audience, months ago from the right maxilla, a lateral or retained deciduous canine and the first premolar were extracted. The right upper canine is completely impacted in the ridge. Implant is already placed at the right upper molar area. Is it possible to extract the impacted tooth and place an implant at the same time? If you look at the panorama, it looks like an implant can be placed after the extraction of the tooth. On the CT image, the impacted tooth looks like it is at the center of the ridge, but as it nears the interproximal area, it is located toward the outside and in contact with the lateral. That is the story from the audience. There is an impacted tooth at the place where an implant is to be placed. This is a very important aesthetic place. We need to minimize the bone reduction during extraction. How do we need to approach this? What needs to be considered for the implant placement? Would you comment on that, please? As Dr. Chung said, crown is palatally positioned, but overall the labial bone looks thin. If we approach the canine from palatal side, it would be very difficult because the crown is there. So I would open the labial side. In that case, the implant site, the buccal plate of that site is very important. So from the top portion of the canine would be reduced to preserve the alveolar bone to the maximum. Here, extraction would be more challenging than placing an implant. In this case, any other doctors? We don't have intraoral pictures, so it is not easy to make a decision based on that. If you look at the CT image, as Dr. Kim said, extraction is critical. After the extraction, if you do not place an implant, there's no problem, but the questioner's intention is to place an implant after extraction. After the extraction, we need to think about how much bone can be reduced and how much stability can be acquired. On the CT, apical portion shows some bone, therefore getting stability is not a major issue. As you said, from where do we need to access the site and how to preserve the bone is an issue. I am of the same opinion. The alveolar process, the buccolingual thickness is thin to place an implant. So regardless of 1-stage or 2-stage approach, GBR is required here. The surgical field would be very big because you need to do both procedures together here. Actually, I had a similar case, but eventually the patient opted for a bridge instead of placing an implant, so I couldn't really find a similar case. Actually, we find many impacted canines, so we need to consider 2 things. The field will get large and additional GBR will be required. As Dr. Kim and Dr. Yang said, implant primary stability needs to be sufficiently considered here. Moderating this case discussion, I got the impression that no simple answers can be provided to questions. I sympathize with the questioning dentists with the difficult situation. If you look at the similar cases, it would be helpful. So our doctors have brought with them similar cases. Dr. Yang, would you start? Looking at that case, what needs to be considered? First is the stability. When a stability is hard to achieve, how can we obtain the stability? That may be the question. Number 37 is planned to be extracted. Due to endo problem, and there's the radio opaque on the image, and it is extracted. 3 months after extraction, we wait. Depending on the causes of the extraction, sometimes we wait up to 6 months, but we make appointment in about 3 months and go in there on the day of surgery. But after extraction, we waited sufficiently with the agreement of the patient. In spite of that, there is no buccal bone and soft tissue is not very good. And on the CT, the ossified bone is not much, and implant is placed. Looking at the buccal bone recession, GBR is done. Insertion torque is 8 Newton centimeters. It's mobile by hand. My criteria is whether it's firm in terms of stability or is there spinning, and the rest is considered poor, but here it says fair. That means stability is obtained from somewhere. So that's my expression. How could we get the stability? And the reason is written here. The bone graft due to extraction and healing problem, as the granulation tissue is removed from the distal side of the implant drill hole, stability of fixture cannot be obtained. So it's a very unfavorable situation. So if you look at what's written in the chart number 2 item, it says osteotome is used to get stability. That means osteotome is used like a chisel. A nail is hammered to an implant. It can be the analogy. That means some pressure is applied to bone to get stability, and GBR is done after some time. RFA is about 80. We waited long enough, and we also did GBR on the left pre-op, and on the right it's immediately after operation. If you look at closely, the bone is sufficient, but if you look at the area where implant is to be placed, the bone is not really mature. If we waited 6 months, it could have been very good, but when the patient comes, we extract the tooth and mechanically we make an appointment for the surgery. However, we waited longer than usual in this patient. Still, the bone is not very good. Another case, this is also endo failure. Therefore, we decided to extract the tooth. If you look at the section, we can get the stability from the apical side, but if you look at overall situation, on the right, the bone, the septum bone is there, but in other parts, no bone at all. On the apical side, a radio-opaque portion remains, and we tried but couldn't remove that. when implant was placed. It looks like it is properly positioned, but it says here it's worse than before. Bone quality is type 4 in mandible, and quantity is good, abundant, but insertion torque is 0. It's shaky, and stability is poor. In spite of that, using various techniques, we submerged that to get some stability. We waited for just 3 months, and the bone is surrounding the implant, and RFA is checked. One is in the 70s, but mostly 80s. It is also integrated. Before we proceeded to the fabrication of prosthesis. The most important thing is implant structure should be to get the stability. Otherwise, we need to get stability in whatever way possible, and then it is submerged, resorting to the natural healing process. So these days, implant surface has been advanced so much. Using some other techniques, we can get some stability like this. I saw 0 Newton centimeter. Is it spinning? It is not just spinning, it's dancing like this. As I said before, the hole got large, so in it is moving freely. Spinning means when we insert it, we can get some torque value. Without primary stability, it can move because of large free gap. But here, it is dancing in all directions. It can be moved with hand, but still, we need to find somewhere where just a little bit engagement can be achieved. It would be a little bit challenging to achieve a primary closure for tissue level implant like SS. So submerging it is a little bit helpful. Dr. Seong, you have prepared a case. Please go ahead. I couldn't find a similar example. As Dr. Yang said, I focused on the primary stability. Dr. Yang used a submerged type implant, and healing abutment would not be mounted, and it's submerged. So in this kind of a case, you'd better use a submerged type of an implant. In my case, when I don't get primary stability, I just don't leave it as it is. I remove it or I wait first. Among the patients, I experienced someone where I couldn't really get the primary stability. Let me show you the case. The patient's bruxism is quite severe. So at number 7, all sorts of problems occurred. It started from number 47. I don't have surgical pictures because I was so nervous. I couldn't take pictures. Number 7, the implant just got in there. It's not spinning. When I inserted it, it just fit in there. That's because the patient insisted on getting an implant, so I could do it. Open membrane technique is used here, and it is submerged. The insertion torque was less than 2 Newton. It is the same as 0. After 5 months, it is healed, and primary stability was achieved. So it's a marvelous, spontaneous healing of body. And the prosthesis delivered after 7 months. Same thing happened to number 37, so I did the same procedure and the prosthesis is mounted. The primary stability was really poor, and I will move on. Number 27, they were extracted for the same reasons, and the primary stability was really poor. Tongue force or muscle force can be excluded during healing, and the implant stays in the stable area, I believe there are chances of success. This is very different from the case under discussion. When you're worried about primary stability, first you need to submerge it. And secondly, you can remove it and wait. This is the follow-up. Post-op 1 year, 2 years. After surgery, I got a peace of mind and took x-ray pictures. Gingival response is good, and it's maintained pretty well. This is not a similar case, but I wanted to show you this can happen from the primary stability perspective. That's why I brought this case. Dr. Kim, would you introduce your case, please? Looking at the case under discussion, I found a very similar case. We talked about the primary stability, and I will cover that too. 53-year-old female patient, no specific medical history. If you look at here, upper right, central, and lateral, roots are all resorbed, and the teeth are mobile. So she wants some teeth, and she doesn't want adjacent teeth reduction, and she wants implants and prosthesis. This is very similar to the previous case with impacted canine. On the CT, the central incisor and lateral incisor will be replaced by implants. Lateral incisor has very narrow space. It is cross-biting, so not enough for 2 implants. Central incisor will get the implant, and it is exactly the place where the implant can go in. Just like the case under discussion, extraction is very important here. The impacted canine, if it is palatally positioned, it is very difficult to extract, and I don't want to recommend that to the local practitioners. So I deal with it as I'm with the university. As I said before, we need to access from labial side, and the roots should be dissected to be removed. Pictures from the initial visit. The lateral is mobile, but it is in cross-bite, and there's no room for 2 implants here. 11 is extracted, and implant will be placed there, and cantilever is used. That is the plan. You can see the canine through the extraction sockets. You need to remove it from the root. The central incisor is where the implant will be placed. The labial bone of the site should be preserved, and the canine is removed in 10 pieces. A TS implant is placed. I don't have the pictures, but only the apex of the implant is touching the bone, labial bone, and nothing else. So it is like freestanding. However, as Dr. Yang talked about primary stability, implant design plays an important role. In the case of TS implant, primary stability is excellent. So up to 2 to 3 apex of the implant are engaged in the bone, so we could achieve pretty good primary stability. At number 12, hardly any bone graft. At 11, allogenic bone is primarily used and is covered with collagen membrane. If I do it again, allogenic bone will be put in near the implant and the socket, but outside, xenogenic bone would be used to reduce the collapse later, but at that time, allogenic bone was popular. If you look at the standard pictures, it was extracted and the implant was placed on the 26th of May. If you look at here, On the apex of canine at 12, one thread, and in the central, 2 or 3 threads were engaged, so it gives a primary stability, and you can see the bone formation. TS3 implant characteristics. Dr. Yang alluded to the thread type implant like this from another company. It's hard to get primary stability from it. TS3 has corkscrew threads, open threads, has very good self-tapping function. So from the apex, initial stability can be obtained with the 2 or 3 threads in the apex. So the case under discussion, I believe you can get stability from the apex. And the initial stability can be obtained like that. Otherwise, you can submerge it. Implant surface has advanced recently, so it's very good. This is the second surgery. The top buccal bone, some of it is removed, and cover screw is removed. During the second surgery, immediate post-op, at the bottom, I was with the Chungbuk University Hospital, and the patient lived far away. Therefore, the patient came back in 2 years. The cantilever is used. Intraoral pictures, it doesn't look very pretty. There was a crossbite, but the patient is very much satisfied. The lateral incisor is discolored before the surgery. I wish I had the CT images. The stability is maintained and the bone level is well maintained. In my view, the reason I show you this is that this is very similar to the case under discussion. As they said, it is very important to choose a proper implant system. TS3 implant has very good, favorable in getting apex stability. So if possible, you can place the implant at the time of extraction. If the bone is damaged a lot during extraction, you can do the bone graft and submerge it and place the implant later in 2 stages. So 3 masters talked about how to treat and bone grafting and how to deal with weak primary stability. I hope this has been very helpful to the questioner dentists. Would you like to give us last comments, please? As I view it, extraction is more hard, so you need to preserve the alveolar ridge during extraction. If labial bone is damaged a lot, preservation, it should be preserved and use a staged approach. I agree with Dr. Kim Kyoung-won. When we do the extraction, most importantly, crystal area buccal bone should be preserved as much as possible. Middle or apical buccal bone is easier to make. So considering that, that should be considered during extraction for better outcome. So we need to pay more attention to extraction. As Dr. Yang and Dr. Kim said, drilling on a slope is very challenging because the drill can slide. Immediate placement is good, but if you cannot drill into the place properly, and if there is an angulation problem, you can extract and wait until the site is healed. So in this case discussion, we talked about whether extraction of impacted tooth and placing implants can be done at the same time. Has it been helpful to you? So it is very comforting that we have at our back excellent masters who can support us, and we will try to answer some of the challenging cases in the future. I would like to thank all the masters who have been with us, Dr. Yang, Dr. Son, and Dr. Kim. I am Jung Young-eun, and I'll come back next time. Thank you. Thank you.
수고하셨습니다. 수고하셨습니다. 네, 고생하셨습니다.